to Dr. Madhu, Uddaraju.
Thank you, ma'am. Thank you once again. So why I preferred combined surgery in Fuchs with cataract, no financial disclosures. So point for combined surgery are cataract surgery, however early your cataract maybe will hasten the decompensation and cause damage to the already compromised endothelium. Staged procedure will definitely have suboptimal visual outcomes because things are not in your control. You can't plan the IOL calculation and others correctly. And with a combined procedure, you'll have relatively predictable refractive outcomes, and there are also logistical advantages to this. So if you see cataract surgery itself, as I've told you, hastens the decompensation in Fuchs dystrophy. Several studies tell that there is a 25% cell loss is inevitable. However, low phaco energy you use or because of the BSS that goes into the eye and irrigation that happens. And there is definitely a need for DMEC or DSEC in these cases 3 to 10 years down the line. It is not like a standalone surgery and you're going to avoid transplant altogether in these cases. So why suboptimal visual outcomes? Because you see with the cornea that is already compromised here, you already have reduced contrast sensitivity and glare corneal because of the corneal edema that is there. So however good IOL you are going to put, the visual outcomes are not going to be great. And there is also, you'll have challenges in IOL power calculation, especially when there is an unstable ocular surface. And best of the IOLs cannot give you good outcomes and the patients will be dissatisfied. Compromised cornea and ocular surface, and post-op also the corneal edema may increase, leading to further complications in the visual outcomes. So how can we do a more predictable refractive outcome in combined surgery? There is a technique called as constant optimization in the IOL formula that you can use when you're doing a combined DMEC with cataract. This has more predictable visual outcomes. And when you're planning for a DSEC, you already know the hyperopic shift that it is going to cause. So depending upon this shift, you can calculate the IOL power and give a better outcome. With PC-IOL in place, emmetropia cannot be achieved. If you're already doing an PCI is already there, then you go in and do a DMEC or DSEC. You don't have control over the visual outcomes. So combined procedure, this calculation can be pre-planned and you can have better outcomes. So logistical advantage, the surgical cost is definitely optimized because you're doing in a single sitting. Cost also is less when that is incurred by the patient. Lesser post-operative visits, at least come down by 50 to 75%. Otherwise, you do your cataract surgery and keep calling the patient till he develops a compensation, and that is going to take longer, and then you do a DMEC or transplant and then again post-op visits. Now that in between time you're reducing here, so that reduction is also important, and it's a permanent solution. And especially when you're opting for lamellar procedures, there are less chances of rejection when DMEC and DSEC when compared to PKs. So why choose a surgery that is built to fail? So instead of that, go in for a combined procedure.